Dear colleagues, dear fellows, it's a pleasure to welcome you to this webinar, ERKNet webinar. We have a good attendance, and today the webinar will be given by Ben Walsh, nephrologist at the Royal Free Hospital in London and an associate professor of experimental medicine at University College London. He has a great expertise in renal tubular disorders and will give today a presentation on distal renal tubular acidosis. Ben, up to you.
Jack, thank you very much. Hi guys. My name's Ben Walsh. Confusingly, my first name is Stephen, so I publish as Stephen B. Walsh. That's how you can find my papers. And I work at UCL. I was asked to give a little picture, which I've given here. This picture, I thought I was going to look a bit like Clint Eastwood when I had it taken. Actually, seeing it again makes me a bit constipated. So there. One thing I always say at the beginning of my talks is that I tend to talk very quickly. So if I'm, so normally what I say is just put your hand up and say, tell me that I'm going too quickly. Obviously, I can't see any of you at the moment. So Jack, if you think that I'm really getting difficult to understand, just let me know and I'll try and slow down. Okay, we're going to start off with some poll questions to sort of give me a feel for the audience. I can't see any of you. I've got no idea what any of you are, what any of the 136 of you actually look like. So the first question is, what are you? Or perhaps, what are you? Are you A, a medical student, B, a junior doctor, C, a consultant or attending, or D, a professor of renal tubular physiology?
Okay, please provide an answer now. Okay, then we have 3% medical students, 37% of junior doctors, 59% of consultants, and 1%, one person is professor of physiology.
Who is it? Okay, all right. Okay, the next question is, how do you find, as a subject, how do you find renal tubular acidosis? Do you find it A, easy to understand, B, difficult to understand, or C, fiendishly difficult to understand?
So Ben, maybe you have to explain the last one. That means extremely difficult?
Extremely difficult.
Okay.
Fiendishly. Like the devil himself.
Okay. Okay, well, 40% finds it easy, 78% finds it difficult, and 7% finds it extremely difficult.
Do you think that person is the professor of physiology? Who knows? Okay, fine. And then finally, how many patients, I guess this is the doctors of you, how many patients do you look after with renal tubular acidosis? Is it none? Is it 1 or 2? Is it between 2 and 5, or is it more than 5?
And then you mean any causes of renal tubular acidosis?
That's exactly what I mean, yeah.
Distal and proximal?
If you've got them, stick them in, because they're all pretty rare.
Okay. Okay, so that's really distributed even, I think, 15% 0, 29 between 1 and 2, 26 between 2 and 5, and 31% more than 5.
Wow, okay, so a pretty expert crowd in that case. So well, shit. Okay, well, let's see what we can do. Okay, I get asked to talk on distal renal tubular acidosis, and that the talk today is on distal renal tubular acidosis. And the reason that I get asked to do this is because I come from UCL, and I've had research mentors who were very big in the field of researching dRTA, and I've also inherited a very large, a very enjoyable clinic, renal tubular disorder clinic, from 2 of my mentors, and I look after a very large cohort of patients with dRTA. So I look after about 40 or in fact over 40 patients with dRTA. And my kind of first mentor was Professor Oliver Wrong, who passed away almost 10 years ago now. Oliver was instrumental in characterizing the metabolic and acid defects in patients with renal tubular acidosis, and he coined the term incomplete dRTA. He also described Dent's disease and published, in fact, continues to publish, has published something like 60 papers since he died. My main mentor is Professor Robert Unwin, and Robert first had the first idea concerning the molecular physiology of distal renal tubular acidosis, and ran the clinic just before I did. And Robert recently retired, but is still active both in industry and in continuing to publish academic papers. Furthermore, at UCL, we have these two rascals. That's Professor Robert Cleater. I think this is quite an old photo because he looks quite youthful there, as he of course he still does. So Robert is a very highly cited, highly published geneticist who has an interest in renal tubular disorders as well as in other genetic kidney diseases. And he is part of a duo along with Detlef Bockenhauer, who I'm sure many of you are familiar with. So Detlef is also heavily involved in genetics as kind of the clinical partner of Robert, and is also involved heavily in ERKNet and in various registries, and publishes extensively clinically and in genetic studies on rare renal tubular disorders. He runs a specialist clinic at Great Ormond Street Hospital in London, which is our national paediatric hospital, and he runs a tubular disorders clinic there. So I get I get a large amount of my patients from Detlef, and in return, when my patients have children, I refer them to him. So UCL has been a sort of very fertile ground for this, and I kind of stumbled blindly into this and ended up with an interest in tubular disorders, and one of those was distal renal tubular acidosis. So, well, you're an expert crowd, so I can gallop through this. This is a cartoon of the nephron. I think of the nephron in a very reductive kind of way. I hope I'm showing you on my mouse now. I think of the 5 bits. There's the least interesting bit, the glom, which is just a sieve, followed by the proximal convoluted tubular, the PCT, which does most of the heavy lifting, but in a not particularly homeostatic way, reabsorbing most of the solutes in the protourine. The loop of Henle, which is involved in free water reclamation. The distal convoluted tubule, which is involved in salt and water, calcium, magnesium transcellular transport. But the bit that we're interested in here for the purposes of today is the collecting duct. The collecting duct, which spans both the cortex and the medulla. And this is a mysterious and intriguing place because unlike the other tubular segments, this has 2 co-existing cell types. And those cell types are principal cells, and principal cells, you'll recall, are involved in salt and water homeostasis. So this is the aldosterone-sensitive principal cell, which expresses ENaC, which is the first route of electrogenic sodium transport in the nephron, and also expresses aquaporin, which is under the control of ADH. So it transports both salt and water through independent control. But intercalated between these principal cells are the intercalated cells, and these cells are involved in acid-base homeostasis. Okay, and so this image you can see here shows a immunofluorescence microscopy, showing in red is antibodies against aquaporin 2, and in green antibodies against anion exchanger 1. So the green cells are the intercalated cells, and the red cells are the principal cells. Intercalated cells, I'm just going to go through a little bit of physiology. I think this is only of a couple of the dreaded box diagrams that we often get in tubular physiology talks. And so in our intercalated cells, we have the hydration of CO2 under the influence of the enzyme carbonic anhydrase 2, and this generates a proton and a bicarbonate ion. The proton is extruded apically through this proton pump, this VH80PAs, and the bicarbonate is extruded back into the systemic circulation in exchange for a chloride via this molecule here, which is anion exchanger 1, which I just showed you previously in the green immunofluorescence pictures. This chloride is recirculated back to systemic circulation via a chloride channel here. And this type of cell is the alpha intercalated cell, and this is involved in getting rid of acid. Okay, the Western diet is acid heavy, and so the intercalated cells that we normally see in humans on a normal modern Western diet tend to be alpha intercalated cells. However, we also have the reverse or mirror image cell of this is the beta intercalated cell. Again, you have the hydration of CO2 under the effect of carbonic anhydrase 2 to form bicarbonate and a proton. However, this time the bicarbonate is extruded into the urine via a bicarbonate chloride exchanger. In this case, it's not A1, but a different molecule called pendrin. That's SLC26A3. And the proton pump extrudes the proton back into the systemic circulation to reclaim acid. Okay, so this is important when you have an excess of bicarbonate, and explains why it's important if you've got someone who's got a bicarbonate load that you give them chloride, because they need to exchange chloride for bicarbonate to get rid of it. Okay. Okay, so if you have the problem with dRTA is you have a failure of renal acid excretion. Okay, and this can happen in one of two situations. It can happen in a common situation. Obviously, if you have renal failure, you are unable to excrete acid through your kidneys if you've had a bilateral nephrectomy, for example, or if you've got end-stage renal failure from any other cause, or anuric renal failure in any case. But you can also have it with a preserved GFR if you have renal tubular acidosis, and that's what these disorders represent. And in fact, when renal tubular acidosis was first described by Fuller Albright back in 1948, he described it as tubular insufficiency without glomerular insufficiency. Okay, that's not entirely true, because you don't have to have a complete preserved GFR to have RTA, but it implies that the problem with acid secretion is not due primarily to your GFR. R. Curtis Morris Jr. MD was apparently a very, very nice man. He was an eminent physician, and so when in 1969, the New England Journal, he proposed a classification for renal tubular acidosis, people felt so well disposed towards him, they did not argue with this clearly disordered, confusing, and miserable classification, which has confounded and made completely unhappy generations of medics and specifically nephrologists. The reason for this is that he posted 4 types of renal tubular acidosis. He called type 1 distal renal tubular acidosis. The reason for this was not because it's the first one you come across as you go down the nephron, but because distal RTA was the first one that was the one that was first described, causes the most severe acidosis, and is the most common. He called type 2 the then fairly recently discovered proximal renal tubular acidosis, which is due to proximal convoluted tubular cells losing bicarbonate, usually almost always in the context of a renal Fanconi syndrome. Type 3 he termed a mixed proximal and distal RTA, which was generally seen in infants. The coexistence of a limited proximal RTA is known now to occur with dRTA, but was sort of thought to have kind of come into existence and then sort of vanished in the early 70s. Because of this, an associated syndrome of mixed proximal and distal RTA caused by carbonic anhydrase 2 mutations also gets called type 3 RTA. And then type 4 RTA was any cause of hypoaldosteronism. Aldosterone, you recall, causes a hypokalemic metabolic alkalosis. So if you don't have enough aldo around, for whatever reason, then you will have tend to have a hyperkalemia and a metabolic acidosis. You can see this in conditions such as Gordon syndrome, for example. As Oliver Wrong often said, you would never clinically confuse distal or proximal RTA for hypoaldosteronism under kind of any circumstance at all, really. So it's a bit of a strange one to pop in there, apart from just the fact that there is a problem getting rid of acid in the tubular segment. So I never use these classification. I would encourage you to not do that either. I talk about dRTA, proximal RTA, or usually Fanconi syndrome, carbonic anhydrase 2 mutations, and hyperaldosteronism. I think is a completely different subject, completely anyway. So that's Curtis Morris over and done with. So let's talk about dRTA. dRTA is caused by failure from any cause of the alpha-intercalated cell. So if anything screws up your alpha-intercalated cell, you'll get dRTA of some severity. Because your alpha-intercalated cells are not working properly, this means you cannot acidify your urine properly, and therefore you will therefore have an alkaline urine. Because you can't excrete acid regularly, you will have a variable metabolic acidosis. Now, this metabolic acidosis is not invariable, okay, because you are able to buffer the acid with phosphate from your skeleton. Okay, so this means that you will tend to, in order to try and mitigate your acidosis, you'll tend to demineralize your skeleton. This will cause one of the two diseases caused by skeletal demineralization. That's in adults, that's osteomalacia. Or if it happens before your epiphyses are fused, then you'll get rickets. Because you're not just liberating phosphate from your skeleton, you're also liberating calcium. Then you have to get rid of your calcium, and you will do this in your urine, and this will cause hypercalciuria. Hypercalciuria is a sign that you're demineralizing your skeleton, and therefore you have not got on top of your metabolic acidosis properly. Because you have hypercalciuria, and because calcium phosphate, the calcium phosphate salt, precipitates preferentially at a high pH, an alkaline pH, you will tend to get crystallization of calcium phosphate, and if that happens in the urinary spaces, that will cause kidney stones. If it happens in the tubules, i.e. the kidney parenchyma, you'll get nephrocalcinosis, i.e. tethered calcium, which does not move but can act as a nidus for both infections and for further stone crystallization. And because in your collecting duct you're not able to secrete protons, positively charged ions, into your urine, then you have to have a situation which, in order to maintain electron neutrality, you have to secrete other positive ions into your urine, and in this case, this is potassium ions. So these patients will tend to have increased urinary losses of potassium and subsequent hypokalemia. Okay, so that is the pathophysiology and the order of how you think of the pathophysiology of dRTA occurring. And you can do nothing about the alkaline urine, okay, but if you can get on top of the acidosis, then theoretically you can get on top of all these three points here, although you won't be able to do anything about the hypokalemia in terms of stopping it happening. You can, of course, supplement it. So bone disease. The bone disease that you get, I said, is osteomalacia. If you do a DEXA scan, the only way you can differentiate osteomalacia and osteoporosis in a patient is to do a bone biopsy. We certainly can't do this in the UK. I imagine that no one else can do them because they're painful, expensive, and extremely invasive. So everyone does dual absorptiometry X-ray scans, or DEXA scans. DEXA scans will show you your bone mineral density. Okay, so it will not be able to differentiate between osteoporosis and osteomalacia. Okay, and I don't know what yours are like, but certainly ones in the UK will say that you have osteoporosis if you have a T-score of less than -2. This does not mean these patients have osteoporosis. What it means is they've got low bone mineral density. In this case, it's from osteomalacia. As I said before, if you get bone demineralization when you're a child, you can get rickets. Actually, I've not seen rickets in this country with any of my patients, but what you do quite frequently see is growth retardation. This is one of my least compliant patients here. Although she looks like she's about 12 years old, she's actually 25 years old, and she is 147 centimeters tall. This lady behind her is one of our clinic clerks, who's also very short, but she's noticeably taller than the patient. And this patient frequently has a serum bicarbonate between 8 and 9 millimoles per liter. They also get nephrocalcinosis. Nephrocalcinosis, as I said, is caused by precipitation of calcium phosphate within the tubules, which means that this calcium is captured within the kidney parenchyma. Okay, this will look like this on a plain X-ray. This is one of Oliver Wrong's collection of radiographs of nephrocalcinosis. In the UK and possibly elsewhere, this is often reported as medullary sponge kidney. And medullary sponge kidney is a cause of medullary nephrocalcinosis. You cannot tell that on a plain film. This is just medullary nephrocalcinosis. Okay. You can of course also see this on a CT scan, which is probably the gold standard of imaging to image calcium. And here we can see the medullary pyramids really very nicely calcified here. And in fact, you can see a stone which is passing through the bladder. Okay, and you can imagine that this is calcium which is really furred up the medullary segments of the nephron. So that obviously is the loop family, but also the collecting duct. Okay, so it's important to appreciate that nephrocalcinosis is a consequence of dRTA. Okay, but nephrocalcinosis of any cause can itself fur up the collecting duct and cause distal renal tubular acidosis. Okay, and there's some pictures we put into a review a few years ago. Cami, who's a fellow here, along with Detlef, did a big study using ERKNet patients, and a lot of the investigators were probably on this call actually. And one of the things that they looked at the paper was the degree of renal impairment that patients with dRTA from a number of different countries get. And what's important to notice here is what we talked about a little bit earlier from what Fuller Albright's description of dRTA, which is tubal insufficiency without glomerular insufficiency. Actually, there is quite a lot of glomerular insufficiency. So quite a lot of patients, 100 out of 144, 100 compared to 44 from the NHANES study, had decreased CKD, a decreased GFR or CKD stage greater than 1. But very few patients, actually, in fact, no patients in the study had CKD 5, an eGFR of less than 15 mils per minute, and a very few had stages 3 or 4. Okay, so we can see the spread of GFRs according to age here is that even our worst ones here were about 20. Okay, so this would still be above the threshold where, for example, patients would get put into our low clearance clinic here for consideration for dialysis. Diagnosis. How do you diagnose dRTA? So the most straightforward way of doing it is if your patient has a metabolic acidosis, so if they have a serum bicarbonate of less than 22, if they have inappropriately alkaline urine, so a urine pH of greater than 5.3, as measured with a glass electrode straight after voiding, then you know they have dRTA. However, skeletal buffering may eliminate an acidosis. So your patient could have dRTA, be unable to acidify their urine, but not have an acidosis. Okay, and of course you or I are allowed to have an alkaline urine and a normal serum bicarbonate. So how do you tell whether someone has incomplete dRTA or not? Well, the way to do it is to provoke an acidosis, and this is what Oliver Wrong described in his QJM paper in 1958 with H.E.F. Davis. And this is a short ammonium chloride test. And the idea is basically just to make someone acidosis by giving them a big load of acid orally. So you give 100 milligrams per kilogram of ammonium chloride. This will provoke an acidosis. And what you should see is when you do this, you should see someone's urine drop to below 5.3 if they have intact acidification. If they have dRTA, they will not be able to do this. There are some problems though. So using ammonium chloride is very difficult to get hold of. And if you take it, it makes you feel really rough. I've had it, and I thought I was going to die. I felt so sick. It's completely vile. Patients often throw up, and if they throw up, it means they're throwing up half their tablets, and it means your test doesn't go ahead. So it's not a brilliant test, but it is the gold standard that we really have for defining incomplete dRTA. So there is an alternative test that we came up with a long time ago now, and that's to use frusemide and fludrocortisone, and that is really it's basically a kind of cheat of making your intercalated cells secrete more acid by using an aldosterone analog and a loop diuretic. So in this case, 1 milligram of fludrocortisone, that's a big dose of fludro, and 40 milligrams of frusemide at the same time. And you measure the urine pH on an hourly basis after this, measuring the urine pH with a glass electrode. This is well tolerated by patients and volunteers alike. I tolerated it fine. Some of my SHOs when I was a registrar doing this were alarmed by how much urine they passed after 40 milligrams of frusemide. but they were all okay in the end. And what's happening here is illustrated here. So here you've got a principal cell. Here you have ENaC, which is regulated under the control of aldosterone, and your sodium potassium ATPase, which is kicking out sodium and bringing in and cycling potassium through this channel here. So you get sodium chloride coming down, passing down this way towards a bladder, and here you have your ENaC conducts your electrogenic sodium transport. So fast sodium transport here. Slow chloride transport goes to the paracellular route, okay, and this electronegative gradient favors the secretion of protons from the alpha integrated cell. If you go frusemide and fludrocortisone, okay, you cause more ENaC to be inserted into the apical membrane of the principal cell. You rev up the sodium potassium ATPase, so you get a really quick movement of sodium this way. You increase your electronegative gradient. And you cause the integrated cells to be going like Billy-O to try and counter this, so you get a very brisk acidification of the urine. And so we did this. What we found is here's the ammonium chloride test, and our patients that we found about 3 hours after giving ammonium chloride, they acidified the urine, so it's just making them acidotic. Okay, in our volunteers, this is our volunteers using ammonium chloride. Volunteers with frusemide fludrocortisone, they did the same thing. They did it a bit quicker actually. And in patients who had diagnosed dRTA, neither of them did anything at all. And here are the actual plots of the healthy volunteers. And you can see that everyone dips to a pH of less than 5.3 with both ammonium chloride. Well, actually, this one guy just skated his 5.3 here. Okay, and everyone else managed it at about 3 hours here and about 4 hours in the ammonium chloride group. However, when you test this in kidney stone forming patients, the ammonium chloride test and the FNF frusemide fludrocortisone test don't always agree. So we showed that in an observational retrospective study. So we found that all abnormal sodium chloride tests were also abnormal by FNF tests, but 13 abnormal FNF tests were normal by ammonium chloride. I guess it gives us sensitivity of 100% and a quite low specificity. Then Daniel Burster's group did a prospective, much better paper, looking at 170 patients. They found a sensitivity of 77% and a specificity of 85%. So not terrible, but not amazing. Not amazing agreement. So I said there weren't going to be too many of these, and I've already got to about 3 or 4. So this is the alpha integrated cell. And it's just to remind you essentially that on this cartoon there are essentially 3 things which are, well, I guess 4 things which are critical to this cell working. The first one is you have carbonic anhydrase catalyzing the hydration of CO2 to form the proton and the bicarbonate ion. Second one is the proton pump to extrude the proton into the urine and therefore get rid of this and drive the reaction this way. The third one is anion exchanger 1, which is going to get rid of your bicarbonate ion and drive the reaction this way. And theoretically, you've got this chloride ion, which is very important to keep the AE1 going by reducing the concentration of chloride. So we've got these 3 things. Oops, these 3 things, which seem to be absolutely necessary. All these 4 things. So anion exchanger 1. Anion exchanger 1 is the main protein in the red blood cell membrane, and diseases, as is present in integrated cells and in red cells. Mutations of this cause about 25% of all cases of hereditary spherocytosis. It also causes a disease called Southeast Asian ovalocytosis, which is a disease which is found mainly in Papua New Guinea, which protects against cerebral malaria. And it also causes distal renal tubular acidosis. This was first posited as a possible cause for hereditary dRTA by Robert Unwin and Oliver Wrong, along with Mike Tanner, first published in the Lancet in 1996. And this funny thing called Grand Round in the Lancet, which is a sort of type of article they did at the time. And this was later proven by Leslie Bruce, along with Robert and Oliver and Mike Tanner in JCI in 1997. So they showed that mutations in anion exchanger 1 cause familial distal renal tubular acidosis. And this was shown in European families and the mode of inheritance in Europe was found to be autosomal dominant. So here's an image I showed you already. These are the A and B are both healthy renal tissue from patients who are healthy. Actually, they're donors, renal transplant donors. And so red shows you aquaporin 2 showing the principal cells, and the basolateral anion exchanger 1, AE1, is shown here in green. Okay, and here you can also see that we've picked up some red blood cells, which are also showing bright green here. As I said, AE1 is the predominant protein in the red cell membrane. C and D are from a patient with hereditary, C is from a patient with hereditary dRTA, and D is from a patient who has autoimmune dRTA. And we can see that their inflated cells are basically these tiny shrunken little things, which are clearly not working properly at all. Okay, and here we have the red showing the principal cells. Okay, so these are obviously got very tiny, small, non-functional intercalated cells. So kind of quite interesting. I mentioned that AE1, when it's found in Europe, is autosomal dominant, but it's also found in tropical countries where it's actually rather more common. In fact, in northeast Thailand, one of the mutations, G701D, approaches polymorphic frequency. It's almost 1% of the population. And these countries all tend to be malarious. Here's a map we put together for a paper that I published with Oliver. In fact, I took my final corrections from Oliver when he was in the intensive care unit shortly before he died. So he demanded to see me so we could get the paper sorted out, which was probably the most stressful revision I've ever done, really. Anyway, I made this map for it, and here we can see the reported cases back in 2012 of various point mutations that cause autosomal recessive AE1 associated dRTA. Okay, and they segregate across countries which have high incidences of malaria and also high incidences of hereditary red cell disease, which these are diseases which are thought to be protective against the malaria parasite in humans. Okay, we also mentioned that the apical proton pump, which extrudes acid into the urine, and indeed mutations in this can also cause hereditary dRTA. So this is the proton pump. It's made of a whole bunch of different subunits. As Fiona Carrott says, you can imagine there's the sort of main part of the pump looking a bit like a bell pepper. It's got all these associated bits and gubbins which are associated in the cell membrane, which are involved in anchoring it and involved in the actual secretion of protons. Very few mutations of subunits of the proton pump are associated with any human disease at all, presumably because they're ubiquitous and that any deleterious mutations are lethal in embryonic form. However, there are two subunits which can cause DRTA because they're kidney specific or almost kidney specific, and that's ATP6 V0 A4 and V1 B0. Oops. These cause autosomal recessive DRTA, and because they're also expressed in the inner ear, they cause sensory renal deafness. Okay, and these were described by Fiona Carrott, which is working at Rick Lipton's group out of Yale, and she described both subunits, the A4 and the B1 subunits in 1999 and 2000, both in Nature Genetics. These patients are broadly thought to have a more severe phenotype of DRTA than the A1 patients. And the A1 patients, of course, don't have the deafness, but they sometimes do have asymptomatic red cell defects. Then the third molecule we talked about was carbonic anhydrase 2. That's the molecule which is involved in catalyzing the reaction of hydration of CO2. This is much rarer than the other two forms and found mainly in cosanguineous families from the Maghreb region of Africa. And carbonic anhydrase 2 is present in the brush border membrane of proximal renal tubular cells. So if you have a defect of this, it also gives you DRTA, but also proximal renal tubular acidosis, cerebral calcification, and osteopetrosis. And the cerebral calcifications often cause learning difficulties. And these patients have quite distinctive round faces with small eyes. I've got one of these patients in my clinic, and the main problem that she really has, I suppose, apart from the cerebral disease, is from her dRTA. This was described by William Sly actually back in the early 80s when he used very classical biochemical techniques to look at carbonic anhydrase 2 activity from biosamples from these patients. And he later confirmed this back in 92 in PNAS by Sanger sequencing. And since then, there have been a couple of other mutations which have been shown to cause hereditary dRTA. The first one is a FOXE1. FOXE1 is a fork-head transcription factor, and we know that it's involved in the regulating expression of transporter molecules which regulate acid-base balance, including A1, including the ATPases, and so forth. And in fact, back in 2004, in JCI, they found a knockout of this replicated distal RTA in mice, and it took another 14 years to find patients who had recessive mutations of FOXE1, which caused dRTA. And these patients essentially have a phenotype which is pretty much indistinguishable from those of the proton pump mutation. They have nephrocalcinosis, so you can see here this is an ultrasound done on in fact, two of the children with the FOXE1 mutations, and these white blobs here are the medullary pyramid calcifications. And they also have, this is a reconstruction made from CTs. So this is control, inner ear, and this big thing you really can't miss. You don't need the arrow to look at it at all. This is the endolymph sac, which is massively distorted in this patient, which is the cause of their central renal deafness. I have one patient in my clinic with this, and the young lady with this is really quite deaf. At the same time, mutations of another molecule were found to cause dRTA, and this was really described in northeast Thailand, in fact, where most of the autosomal recessive AE1 mutations have been described. So by the same group, and this is mutations in a binding and scaffolding protein called WDR72. And this caused a syndrome of a myelogenesis imperfecta. So that's hypomineralization of teeth, nephrocalcinosis, and distal renal tubular acidosis. Okay, and this was first described by Rundroj and this chap here, Paitai Yejitsumanis. He's done loads and loads of work on dRTA in northeast Thailand. And they showed that I think it was three children from Thailand and one child from India all had dRTA, nephrocalcinosis, and this myelogenesis imperfecta. Now, WDR72 had been shown to cause a myelogenesis imperfecta previously, but had not been shown to have a renal phenotype. There have been a few papers been published since then. This is one in Pediatric Nephrology from 2020, and this actually showed there's quite a lot of phenotypic variability. So they got some other patients with WDR72 mutations, and it showed that they had a renal phenotype with nephrocalcinosis, but when they gave them furosemide fluorocorticoid, they were able to acidify their urine normally. So the question is, how does this cause RTA? So this is some of this classic sort of teeth, and this is a dental PEG. So you can see lots and lots of unerupted teeth here, and these very sort of hypoplastic, very unusual looking teeth here. Cosanguineous family with one affected patient. There is another beta propeller scaffold protein called WDR7, which is known to associate with proton pumps, although the homology between that and WDR72 is only 58%. So that's really not very similar. One thing I will say is all the described, it's not very clear from this paper, but all the described patients in most of the other papers have all been known to have nephrocalcinosis. And we know that there are some other diseases which cause a myelogenesis imperfecta with nephrocalcinosis without causing dRTA. For example, mutations of FAM28. So I do wonder whether these patients have dRTA as a secondary consequence of nephrocalcinosis rather than the other way around. However, at the moment, there are knockout mice which are WDR72 knockouts. No one has yet published the description of the renal phenotype, so we're still a bit in the dark as far as this one's concerned. Okay, I'm an adult nephrologist, so I don't just look after patients with hereditary dRTA. I also look after them with acquired dRTA. And if you look up dRTA in a textbook or online, then you'll find out a big list of things which cause acquired dRTA. And so well, let's just go through it. The first ones are autoimmune causes. Now, all of these autoimmune causes will all cause a tubulointerstitial nephritis, and it's the TIN which causes the dRTA. Okay, by far and away, the most common cause of this is Sjögren's syndrome. Okay, I'll talk about that in a second. It's described with lupus. It's described with autoimmune, various other autoimmune diseases, and it also happens with hypergammaglobulinemia of any cause, and that's because hypergammaglobulinemia is a cause of TIN. It's described with renal allograft rejection, which of course is just a TIN in a renal graft. So I think it's entirely reasonable to suppose that the mechanism of that is exactly the same. dRTA can cause and also be caused by any cause of nephrocalcinosis. Okay, so anything that causes hypercalciuria can cause nephrocalcinosis. So things like primary hyperparathyroidism, medullary sponge kidney, sarcoid, TB, you name it. These can all cause nephrocalcinosis and therefore cause a secondary dRTA. So there's a very good description. I was skeptical about this until I read some of the old reports, especially around vitamin D intoxication, causing a de novo dRTA in an adult back in the 1960s, I think. It's also caused by drugs, ifosfamide, cisplatin, both act as direct tubular toxins. Both of them preferentially cause proximal tubular dysfunction, but can both cause distal tubular acidosis. Amphotericin B comes up again and again in the old literature. I've got to say, I've never seen it with amphotericin, even though we use quite a lot of it with our line-associated fungal sepsis and that kind of stuff. And then finally, you get it with Wilson disease. Again, Wilson disease is generally thought of as causing Fanconi syndrome, but it definitely also causes dRTA. I've got 2 of these patients. And it's often said to happen with obstructive uropathy. Actually, I think that's probably a problem of terminology. I think it tends to occur with what we used to call vesicoureteric reflux, we now call CACUT. And I think that's more to do with scarring and damage in the collecting duct, although I've got to say I'm pretty agnostic about that. But what we can really boil this down to is that the one standout reason for acquired dRTA is in over 90% of patients is going to be Sjögren's syndrome. So Sjögren's syndrome, I'll put omelette there because I'm European like you are, is what's known as an autoimmune epitheliitis, has been called that. And so it's an inflammation that primarily affects secretory epithelia, which is why it gives you a Sicca syndrome. That's why it gives you both lacrimal gland and salivary gland inflammation, so dry eyes and dry mouth, causes airway disease, causes biliary disease, but it also causes a lot of renal disease. Here's a renal biopsy from a patient with Sjögren's syndrome, and you would think of this as probably something which is perhaps, if there's a renal transplant, you might call this something like chronic rejection or chronic allograft nephropathy. So we've got lots of areas of scarring with a dense blue inflammatory cell infiltrate. If you characterize this infiltrate, you'll find that it's CD3 and CD4 positive, and it probably mainly comprises of CD4 helper cells and Th17 cells. There have definitely been autoantibodies described with this, and autoantibodies against some of the alpha-integrated cell components. Whether that means that the infiltrate is secondary to primary autoantibodies, or whether you've got an inflammatory cell infiltrate chewing up integrated cells and exposing those epitopes to B cells to cause antibodies, well, essentially no one knows. I've got quite a large cohort of ladies with this, and we treat them. These patients are almost always on hydroxychloroquine when they arrive. And what I do is I normally biopsy them, and if I find they've got this infiltrate, I start them on a short course of prednisolone, which tapers down over a month, and I start them on mycophenolate with the aim of getting their IgG levels into the normal range. These ladies almost always have hypergammaglobulinemia. The use of rituximab, we've given rituximab to a couple of patients with this, with 1 success and 1 failure, mainly due to her having an anaphylactic reaction to rituximab. Although the use of rituximab as a CD25, anti-CD25 molecule is therefore an anti-B cell molecule, and that appears to work quite well. Again, we wrote this up in a couple of rheumatology journals. I'm not sure how many of you are English. I should have asked how many of you are actually English. If you're English, you're exposed to Charles Dickens quite a lot. Charles Dickens was a Victorian writer who liked to write about sort of terrible, squalid poverty in Victorian England, mixed with sort of terrible cruelties. This is the sort of thing that Boris Johnson is trying to get us back to here in the US Kingdom. And there's one of his most famous books called A Christmas Carol, and in that they have this character called Tiny Tim, who's the protagonist's crippled son, or the kind of the main goodie's crippled son. He's known that he's kind of has paralysis. He's got a gammy leg. He can't really stand up. He's intermittently weak. He's very short, and we're told that unless he gets some kind of treatment within 1 year, he's probably going to die. And we know that back in Victorian times, that the sort of things that they used to use for sort of pediatric tonic, I think I'm not sure it's changed very much in pediatrics actually, honestly, were these kind of fish oils and tonics. And fish oils are rich in vitamin D and that kind of stuff, things which will increase your serum calcium. The tonics they'd be rich in salts of sodium bicarbonate, sodium citrate, potassium chloride, so all things which are good for you in renal tubular acidosis. They'd often have opium in, so to help with the pain of renal of kidney stones, and belladonna. So obviously you'll be looking your best if you're like this. So perhaps belladonna might give you a little bit of pupil dilatation and make you a little bit more presentable to the people around you. And so it's put by this chap back in 1992 in the archives of Pediatric JAMA, and Tiny Tim had dRTA, which I guess is the it's hard to think of how many other plausible diseases that you might have that could be cured by this anyway. And so we've gone to the treatment. So what things can we treat these patients with that's going to make them better? And I kind of think there are kind of four parts to the things you need to think of when treating someone with dRTA. And the first one is that these patients get stones. So there's dietary things that you can do here. Okay, so first of all, you need to be making sure these patients are drinking plenty, trying to have a dilute urine that are less likely to crystallize calcium phosphate crystals into. In fact, what you'll find is most of these patients are already drink loads anyway. It's also your main intake of acid is not from acidic fruits or so forth. It's actually from animal proteins. That's cysteine and methionine, which are sulfur containing proteins. So if you can convince your patients to become as vegan as possible, then you can massively reduce their alkali requirements. Some are interested in doing this. Some are very resistant to it. The ones that my patients who've become vegetarian or vegan have reported feeling better and reported, it's anecdotal at the moment, but decreased stone frequency. These patients are unable to secrete acid and they have potassium losses, so you need to replace their alkali and their potassium. So you can place that in a bunch of different ways: sodium bicarbonate and all potassium supplements, and you can combine these with potassium citrate. Citrate is metabolized by bicarbonate by the liver, and therefore giving citrate theoretically gives you a longer lasting base than using sodium bicarbonate. Potassium citrate, of course, also gives you your potassium at the same time. Potassium citrate often causes dyspepsia. At the moment, I use a formulation called Urosic K, which is supposed to help with that. I've got to say it's not brilliant. There are some other ones in development at the moment also. Sodium bicarbonate is more palatable but gives a lot of gastric gas. So it causes loads of belching and bloating, which people either don't mind or they really hate. Either way, these are things that you've got to try and convince your patients to take forever. And these things, of course, don't make them actually feel any better when they take them. They're usually meant to feel a bit worse. So compliance is a big problem with these replacement salts. It's usually worth spending a bit of time trying to get your patients happy with what you're giving them. These patients get recurrent stone disease, and the stone disease is much worse if they've already got nephrocalcinosis. Remember, if you've got calcium which is tethered to kidney parenchyma, it acts as a nidus for further crystal formation. So it's very difficult to get patients who've got existing nephrocalcinosis. Often it's difficult to stop them getting stones. If they don't already have nephrocalcinosis, then which the Sjogren ladies often don't have, then sometimes you can abolish it by reducing inflammation. In any case, I'll probably need urological surveillance. So you can find an interested urologist who's interested in stones, is interested in looking after these patients, is a very good thing to do. And early expectant treatment for stones which are already there. Oops. And also they have bone disease. Okay, so we undertake surveillance DEXA scans about once every 3 years, and it's important to try and abolish hypercalciuria. Okay, so you're actually stopping that bone demineralization altogether. So what we do, we monitor their urinary calcium excretion in addition to their bone DEXAs to try and get it under control. And I think that should be about it. So so that's my email address. I'm happy to be emailed by any questions or queries about this sort of stuff. And I'm happy to take questions.
Okay, thank you very much, Ben. I think we don't have any other questions from you. There's no exam questions, huh?
I'm afraid not, no.
Okay, we go to the questions of the audience. One question is about the fact that the ATP6V1B1 protein is expressed in male genital organs. So one question is whether you know whether these patients have infertility.
Oh, that's an excellent question. Yeah, so an acid base is really important in the kidney. It's important in the inner ear, and it's important in the testes. And the testes, in fact, the testes. If you look at gene expression or protein expression, the testes basically express pretty much everything, including ACE2 for people who are interested in what COVID might do to you. So as far as I'm aware, no one has described infertility in these patients, although it has been wondered about. I haven't got any male patients who've got these problems, so I have no direct experience. I don't think it's in the literature. So, but I guess it's possible.
Okay. Then another question is about the incomplete renal tubular acidosis. Is it a different entity, or is just, you know, within the spectrum of the genetic and acquired RTA and depending on what patients are eating?
Yeah, okay, so there's been loads of confusion about this in the literature as well. So lots of people seem to be really confused about this, and so unusually, I think I can probably help a little bit with this. So we have patients who are either homozygous for autosomal recessive causes or heterozygous for autosomal dominant causes of hereditary dRTA, and some of them have overt full distal renal tubular acidosis, and some have incomplete. Okay, so there's been speculation in the literature saying, oh, is this a disease of heterozygotes, or is it an incomplete form, or is it incomplete penetrance, or this kind of stuff? I can't say that's not the case. But what I can definitely say is the case is that patients you would expect genetically to have the full-blown syndrome, some have incomplete dRTA, whereas others with the same mutation, same point mutation in the same family will have complete dRTA. So I think the most likely explanation for that is differences in diet. There could, of course, be other modifying, regulating proteins which have polymorphisms or what have you. Okay, but diet does seem to make a big difference, and diet is one of the things that was never really looked at in any of the papers about this. But for sure, you have some patients will have incomplete dRTA, yet with the same genotype as other family members who have the full-blown thing.
Okay, thanks. Another question is about this issue of CKD and distal tubular acidosis. One question maybe to start with is the figure what you showed with the prevalence of renal dysfunction in patients with renal tubular acidosis.
Yep.
That's the genetic RTA.
So there's 4 groups here, which you can't see in this. They were groups who were supposed to have primary dRTA. So these reported across the ERKNet network, in fact. So primary dRTA. So I think the assumption was they were all were pediatric diagnoses originally, and they were either the 2 proton pumps, group 1 and group 2. AE1 was group 3, and then unknown was the 4th one. So
okay,
they were should all have been genetic, but not necessarily all genetic diagnosed. Yeah.
So. If you think about adult patients who present with distal renal tubular acidosis, what is the likelihood that patients with a genetic form of distal renal tubular acidosis present in adulthood and are not already diagnosed during childhood?
So I am unaware of any patients with a proton pump subunit mutations who have been diagnosed in adulthood. we definitely have adults who have been diagnosed with AE1 mutations, and in fact we've had probands and then done family screening and found other affected members who were in middle age who were asymptomatic with full genotype, so incomplete dRTA in fact. So you can definitely have AE1 associated mutations, associated dRTA, and present in adulthood. So we definitely see that.
Okay. If you have a patient with distal renal tubular acidosis who presents to you with also, let's say, CKD stage 3A, can you do the same tests to diagnose?
Yes. So one of the great things about looking at these old papers is Oliver's paper where he described the acidification tests that he used, the short ammonium chloride test. That paper is about 25 pages long. It's a colossal paper. And one of the things he did is he measured urine acidification in patients with CKD. And I think the patient who had the worst renal function had a creatinine of 400. So that would have been someone who's definitely got CKD 4 or 5. And they were able to acidify their urine properly with an acidification test. So what we haven't done is done the frusemide fluorocortisone test. You would expect frusemide to be much less effective with low GFR, obviously because it's got to get into the tubule to work. But in terms of giving someone an acid load, they can definitely acidify normally in response to a provocative test like that.
Okay. When you are treating patients with dRTA, are you measuring urinary calcium excretion, and how low do you want them to go?
So I know that Detlef measures the urinary calcium creatinine ratio, which I think is a really good thing to do. I'm just not really, I can't really think like that. So I measure the fractional excretion of calcium, and I want to get it in the normal range, or get it as low as possible, basically.
Okay, thanks.
And you're wanting to do that essentially with alkali treatment. There are some tricks you can do if your patients are non-compliant. So I've got a couple of patients. In fact, the very short patient I showed in an earlier slide is her disease is quite bad because she's completely non-compliant with her supplements, and so I use a thiazide in her. Not with brilliant success, but thiazide is a way of reducing hypercalciuria and increasing serum bicarbonate. Detlef's very against that, but I think adult patients are worse with compliance than kids are, I guess.
Okay. Well, in view of the time, I think this ends the question session. There are still more than 10 questions open, but you have showed your email address, so you can expect questions coming in the next couple of days. I thank you very much for your presentation, and I thank the audience, and I would like to recommend to them the other ERKNet presentations, which are the next one is giving, I think, in 2 weeks on C3 glomerulopathy, and then we have other webinars in February and beginning of March. But thank you, Ben, for this excellent presentation, and I thank the audience and wish you all a good day, and see you at the next webinar.
Cheers, Jack. Bye now.
Okay, bye-bye. Okay. Well, Stephanie, thank you.
Yeah, cheers, Stephanie. Is she gone?
Oh, yeah, thanks. Thanks to you. Bye-bye.
Okay, well, yeah, bye-bye. Thank you.
Yeah,
see you next time.
Hope to see you in real life soon.
Okay, bye-bye.
Bye now.